I know some of you are tweeting. You can tweet at d.health 2016, and our handle is hashtag d.health 2016. Next, it's my pleasure to introduce our next panel, and Paula Spann. Few people have devoted as much time, energy, or ink to highlighting the challenges and successes of aging as the moderator of our next panel, Paula Spann. In a recent piece for the New York Times on a daughter who moved back to care for both her parents with Alzheimer's disease, Paula recorded from the daughter, "They've been here at home 40 years. All my dad ever wanted was this home. Who am I if I take my dad from his home?" Paula. And then the panelists can come on up. The panelists can join.
You good?
Paula's on 7. Paula's not on 7. Great.
Good morning, everybody. My mic's okay? Yes, I'm Paula. Nice to meet you all. My column for the New York Times online and in print is called New Old Age. I am the one on the stage with no initials after my name, MD, CEO, MPH, none of that. But I would argue that we really don't need initials to grasp the problem that our fractured healthcare system has in delivering care to older people who have multiple chronic diseases, and of course that is most older people. So if you work with older adults, if you're a caregiver for an older adult, if you are an older adult, you see how easy it is for someone's life to become an endless cycle of visits to clinics, sitting in doctor's offices, making more appointments, punctuated by the occasional emergency department visit, and a stint in rehab, and then around again. And everyone who looks at this says there has got to be a better way to deliver care to people with chronic conditions. And our panelists today, all of whom do have many initials after their names, are all leaders in the ongoing attempt to find those better ways. So let me introduce them to you. I'm going to emphasize not their many awards and degrees, but what they're doing now to improve chronic care. So all the way on my right, your left, is Dr. Bloem, who's a neurology professor from the Netherlands, who 12 years ago, hoping to improve care for people with Parkinson's disease, began Parkinson Net. It started in one small city with 20 physiotherapists. It now operates throughout the Netherlands, and it has been adopted by Kaiser Permanente in California. And Dr. Bloem has plans to introduce it in Norway and in the state of Michigan, and I will leave it to you to guess which of these entities has the planning going more smoothly. No points if you guess right. Stephen Landers, the CEO of the Visiting Nurse Association Health Group in New Jersey. That is the nation's second largest not-for-profit visiting nurse association. It serves 120,000 households a year. And his group has adopted a number of mobile and digital technologies, which Steve will tell you more about, to improve home-based health services for seniors aging in place. And as you just saw, that almost everybody would prefer that. Cynthia Boyd is an internist, geriatrician, and epidemiologist at Johns Hopkins who helped develop guided care, in which primary care nurses help frail elderly patients to manage their chronic conditions. And now she's working on a new program that's intended to increase communication between home health agencies, which are often many small independent companies that are supporting seniors in their homes, and the physicians that are helping to make medical decisions for those clients. And finally, Shelley Lyford, can you tell which person here is from California? Is CEO of the Gary and Mary West Foundation and West Health, and notably, she is chair of the brand new Gary and Mary West Senior Dental Center, which is about to open in a senior center in San Diego, and it will offer not only oral health care, which we all know is a major healthcare gap for older Americans, but it will also offer comprehensive geriatric assessments and treatment and referrals, incorporating a number of technological innovations. Now, each of these folks could easily fill an hour talking about their findings, experiences, and plans, but instead, we had the chutzpah to ask them to just talk for 6 or 7 minutes. and then we'll have a 10 or 15-minute conversation, and then we'll ask all of you to chime in with questions and comments. So, Bas, I'm going to ask you to kick off the conversation.
Seated or standing?
You may sit.
Still be taller than...
The 6'8" person can sit. The 5'1" person can't.
So thank you, Paula. Thank you, Ray, for inviting me. Ray asked me to come all the way to New York to tell you why I think healthcare is organized in a completely wrong way, at least when it comes to chronic patients. Just take Parkinson's disease as an example. It's a horribly complex condition, debilitating, a variable presentation across patients, very difficult treatments. It includes medication, deep brain surgery. It includes allied health. And yet we leave the care for these poor individuals to generalists alone. In fact, research has shown that in the United States, 1 in 3 Parkinson patients never gets to see a neurologist, let alone a movement disorder specialist. Now, make no mistake, I know there are geriatricians and gerontologists in the audience, and I'm a great fan of generalists. I just think that many chronic disorders are way too complex to be left to a generalist alone, and that for some specific problems, you need experts. And the second problem is that we tend to organize care in institutions. They're almost like medieval castles with thick walls, a moat and a drawbridge. And while I think that hospitals have some added value, particularly for acute care, I think chronic patients are best staying out of the hospital and staying at home. So our Parkinson Net approach that we developed in the Netherlands has 5 cornerstones. The first is that we organize care along the pathway of Parkinson patients, starting in the patient's home, and it includes welfare. I was very much struck by the previous panel discussion, all the way up to university medical centers, but including the community-based care, the community hospitals, and the university medical center. Second, within these integrated networks, care is not just left to everybody doing a little bit of Parkinson's, but we've trained a limited number of professionals who each have a dedicated training in Parkinson care, attract a high caseload, and work together as a team. And by attracting a high caseload and working together, you deliver better care and improve your expertise. Third, we treat patients really as a partner in healthcare, not as a hollow phrase, but we have a range of opportunities, and I'm happy to discuss them at more length after my talk, to engage patients as a partner in healthcare. Just one example is our web-based healthcare finder, a web-based search engine where you just type the discipline you're searching, maybe a physiotherapist, the city you're living in, the distance you're able and willing to travel, and Google Maps will give you the individuals trained by my network, and you can book your own appointment. So patients decide when to go, where to go, and book the appointments. That's putting patients really in the driver's seat. Fourth, we try to deliver care close to the patient's home and outside of the hospital in a number of ways, including telemedicine. And fifth, we develop technology not as a tool in its own right, but as a mechanism to deliver our other 4 missions. I've seen many gizmos and other technology solutions fail because they are presented as an isolated solution. Our mission is care close to the patient's home, the patient as a partner, professional expertise and integrated care, and you can use technology to deliver those missions. Now, our research has shown, this is a number of clinical trials published in The Lancet, in the British Medical Journal, high-end journals, to show that quality of care gets better, better knowledge of guidelines, better adherence to these guidelines. The number of hip fractures in the Netherlands, thanks to the expert care, has gone down by a striking 50%. And healthcare costs have gone down by 30 million euros for Parkinson's care in the Netherlands alone. That's a 6% reduction in our chronic annual expenditure on Parkinson care alone. And just imagine what would happen if you would copy that model to diabetes, dementia, rheumatoid arthritis, or other chronic conditions. Not by working harder, but by working in a different and more clever way. The interesting thing is that we've attracted a lot of international attention. There is now a Parkinson Net up and running in Southern California in an exciting partnership with Kaiser Permanente. We're scaling to Northern California this year. We've been holding discussions in Michigan which have been outrageously complex because of the many providers and many insurers that are in competition. And we're probably going to roll out to the entire country of Norway very quickly. because Norway is like a big Kaiser Permanente. It's one provider and it's one central insurance mechanism, which I find a way lot easier. Taken together, integrated care, the patient as a partner, professional expertise, delivers better care at a lower cost. Happy to share that expertise with folks here in the audience.
Right. Steve, you're up.
Great. Thanks so much. Hard to follow. Steve Landers, by background, and really the main reason I'm here, one message is as family doc, geriatric medicine doc, and really a little over a decade ago got to focus my work on doing home visits and fell in love with home care, really just the access that it provides patients, the gratitude of home visitation, particularly for family caregivers and people with serious chronic illness that are living in the shadows, and also what you learn about people that we don't see in the sterile settings of offices and hospitals. So it was a real special honor, really the best thing that ever happened to me professionally certainly was to be able to, 4 years ago, move to New Jersey and become the CEO for Visiting Nurse Association Health Group. And what we do is we provide all sorts of home and community-based services throughout the state of New Jersey, mostly to elders with serious chronic conditions, people struggling to get home and stay home from hospitals and facilities when things have gone bad. We do skilled home health services, personal care services, hospice care, which is primarily a home-based model. We have a 30-provider home-based physician and nurse practitioner service that provides in-home primary medical care. So we're really advocates for supporting people at home, supporting the caregivers at home, but we're not particularly satisfied. We love home care and we believe in home care, but we think it can be so much better. We think that we can do a better job, and what we've embraced is using connected health technologies, connected health concepts, better use of data analytics, apps, monitoring, video conferencing, communication technology to improve what we do. And so we envision a future where in between our visits, patients and families are better connected to us with multi-channel resources, online resources, video conferencing, what have you. We think that people should have self-service options for scheduling, for interacting with us, so that they're not always at the whim of an old Soviet phone tree. We envision a time when we can improve quality using connected health concepts by better targeting what we do, making better decisions about who gets visits when, based on analytics, having better, more robust patient education, caregiver self-management tools, so they're not just left with an old copied handout of instructions of what to do, that maybe they have multimedia resources of what to do. And we envision being able to do what we do more efficiently and be more useful of the resources that we have, the precious human resources, so that we don't waste time, that we don't waste resources, so that we can put our money and resources into helping people with care. So, we are doing many pilots. We've worked on, trying different models of integrating video conferencing, different models of remote monitoring. All of our clinicians are on point-of-care mobile devices, and we've done some work with using video conferencing among our staff as a staff development, learning development model using some of the Project Echo concepts and tools. And we're also working on a new data integration project where we realize that if we ever want to really change what we do, we have to get out of the limitations of the workflow of our existing IT platforms. We're moving our enterprise data from the different systems into a more integrated but secure data environment that's open source, where we can maybe take advantage of the rise of the developer community and start to rethink what we're doing. And but that said, we're still, a lot of our work in telehealth, connected health, is bolt-ons, it's add-ons, it's pilots. We really want to actually change what we do, redesign the workflows, process, and model for what we do, so that we can take advantage of the opportunities that technology provides to do all those things: better experience, better quality, more efficiency. So we're going to be actually reaching out soon to some potential design partners, hoping to find someone to engage with us. And it's necessarily not my expertise as a family doctor. How do you redo your systems and processes? But that's where we really need to go. If we want telehealth, connected health, digital health to be part of the mainstream of what we do in elder care, we as leaders have to recognize that we're going to have to change what we do. It's not just going to be somebody's going to come along with some magic wand that's going to make everything easy and better for us. We have to change to take advantage of these things. So that's where the the focus is, and I think that the future is bright. It's really on us. There's a lot of barriers in regulatory and payment. You don't get paid for this. You're going to get it right. But look at what some of the innovators have done, some of the leaders have done in healthcare. Until we're all up to where the best are, we've got a lot of room to go on our own without being sort of strapped in or limited by the limitations.
Thank you. Cynthia.
So I am a geriatrician and a primary care physician, and have been interested and compelled for a long time for how we really sort of transform care for people with multiple chronic conditions. So much of the way medicine and public health has approached care has been the single disease at a time. But the idea that we can just add up what is recommended or needed for each condition when people have 3, 4, 5, or 7, and that's actually the right thing to do for them is really I think that's missing the sort of the big picture of how we should really approach people with multiple chronic conditions. If we do that, it actually may be harmful. So how do we think about how we transform care so that we're not looking at people as sort of the sum of their individual conditions, but really figuring out what matters to them and how can we help them achieve that? And we think we really need to do that long before we're thinking about hospice. So I think thinking about what the solutions are, and I think tied into this is actually what makes it fun to do the work. In the morning, someone was talking about how these really complex decisions are in sometimes perceived as less attractive or less fun. And I think geriatricians, family physicians, and probably many of the other people in the room are actually really drawn to that complexity. But I think what makes it engaging and worthwhile is hearing people's stories and making sure that those stories are continuing to inform care. So not just for the people who are helping us design technology, but for every single person that we see, how do we make sure that kind of who they are and what matters to them is conveyed, and how do we use technology as a tool to make sure that that's carried forward and that we stay focused on that. So I've been involved for a long time in programs that are related to how do we increase the ability for primary care to help be a home to take care of people with multiple chronic conditions and connect to all the other sites where patients with multiple chronic conditions are and want to either are or where they want to be. So guided care embedded a nurse into primary care practices to do a number of tasks to focus on transitions, to empower family caregivers, to help people with self-management. And it was really meant to be focused on people with complex health care needs. And I think it's really was an early prototype of this kind of model that was trying to not just add up sort of individual conditions, what's recommended for them, but really trying to shift focus to the whole picture of what people need. And I think that there were many lessons that were learned. I'll just highlight a couple of them. But a key one, which has been brought up a little bit, but is targeting is who do you really want to find to deliver a service for, and making sure that that is well matched with the intervention that you have and the tools, be them technology or otherwise, that you're going to use. And how do we figure out what the right outcomes are to be measuring, and making sure that all three of those things are really lining up in such a way? Because I think if any of those things are off, it may not really maximize the potential. A second thing is that when we're doing this is really multifaceted, as Steve was just talking about how we have to change, that if we improve one piece, we need to make sure that the rest of the parts, the health system and the way we actually deliver care, are really ready to be ready to also be changing and to be reacting. So if we improve patient and family engagement, that the system is really prepared to use that information and use it well. And then finally, I think it really comes back to the way we design things. We were trying to take the next step beyond sort of the adding up the single disease approach to care, but I think that we still have a long way to go in knowing really how to do that. And I actually think that focusing on what matters to people is actually really very disruptive, and that it is a big shift from much of the way we've designed care. And so we need to learn how to figure out what matters to people and use that to continue to inform the decisions that we make and make sure that it's keeping people engaged in their families and in their communities. And I think that technology is really should be used as a tool to keep the healthcare system focused on what matters to people.
Great. Thanks so much. Shelley?
Okay.
Proceed.
Well, good morning, everyone. It's a pleasure to be here and to be on this great panel. I am delighted to represent West. At West, we have 3 different organizations. We have a foundation, an applied medical research organization, and a policy center that all work together seamlessly under the same umbrella mission. And that mission is called Successful Aging. So what I'd like to outline to you in the next few minutes is one example of how our 3 organizations are working together to create a new model of care that is addressing a major chronic condition in this nation. At West, we're focused on creating these new models of care that are not only innovative, but are also low cost and leverage our current community assets. So we're really not focused on rocket science. There are probably some rocket scientists in this audience, but we're very focused on things that are practical, things that are thoughtful, and where can we meet the seniors in need that we are most interested in serving. And that subsection of seniors that we're most interested in are actually seniors who are living at or below the poverty level in the United States. Does anyone know what that number is, or what the dollar amount for poverty level is in the United States? So, that's right, Paula. It's about $20,000. 40% of America's senior citizens are living at or below the poverty level. 40%. The seniors that we serve in San Diego have about $5 of discretionary income that they live on per day. Imagine living on $5 per day. That means no Starbucks. That means you are making a decision every day whether or not you're going to buy your medicine or you're going to buy food, or whether you're going to pay your rent. So these are hard decisions that seniors are making in every county of our nation. And at West, we are excited about leveraging the important community assets that almost every community has to be able to create a new model of care that is going to meet seniors where they are, at their home or in their communities. The most prevalent chronic condition in our nation is dental disease. I was shocked to learn that. If you had asked me a year and a half ago, I would have guessed something very different. And Boz, you said that you wrote a paper about it when you were about 18 years old.
Yeah, this big.
Yeah. He was only 5'2" when he was 18. When I was 18, I wouldn't have guessed that. About 10 years ago, Gary and Mary West, the philanthropists that I work for, created the Gary and Mary West Foundation. And at that time, we made the decision that we were going to focus on creating opportunities for seniors to live with independence, to live with grace, to live with safety. And in our quest to fulfill our mission, we created the Gary and Mary West Senior Wellness Center, which is located in downtown San Diego. It's located on a trolley line. It's located on a bus line. It's located within a few blocks of some Section 8 housing. And we serve over 900 seniors a day. The seniors primarily come to our senior center because we are open 7 days a week, and we provide 2 meals a day. We are one of only 3 senior centers in our nation that are open 7 days a week and provide meals every single day. I like to eat every day. I normally don't take the weekends off, and we found that our seniors would prefer not to take the weekends off as well. But what we discovered through our unique senior center, which is a unique model in and of itself, and I could speak about 30 minutes on just the senior center, we have about 30 nonprofit organizations operating under one roof. So to the senior that comes to our senior center, he or she is receiving what they think are seamless services. Everything is integrated. The whole person is being addressed. It doesn't matter if you're coming in for case management or nutrition or a health need, or if you want to take a Tai Chi class or learn about computers. You can get everything you need in a one-stop location that's easy to access for the seniors living in an urban setting in San Diego. We discovered through the years that some of the seniors that were so engaged at lunch and breakfast and excited to be at the table with their friends, all of a sudden were starting to sit back. We're starting to put their hand over their mouth. We're starting not to show up. And we were trying to figure out why. And the reason was because their mouths hurt and their teeth hurt. And they had abscesses in their mouth, and they were losing their teeth, and they became embarrassed. And not only were they in pain, but they started to withdraw, and they didn't want to talk to people, and they didn't want to smile. And our rates of depression were increasing. And I think many of you know that Medicare does not cover a dental benefit in this country. There are about 28 states that have a Medicaid benefit that would cover a dentistry, but there is still a significant gap in seniors being able to access services. So with that, our foundation decided to kickstart an opportunity to really leverage the community in a meaningful way. We provided about a $1 million grant, a capital grant, to create a dental center, a 4-chair dental practice within the 4 walls of a dental center where we know all of our seniors are going to come every day. We're able to integrate this dental center. We just got our community clinic license about 2 weeks ago, and we will open the doors to our dental center in about a month or so. We will operate our dental center in an integrated fashion using technology like a comprehensive geriatric assessment. So no matter what door a senior comes into our senior center, a dental door, a social services door, a nutrition door, a housing need door, that senior will get a comprehensive geriatric assessment. That geriatric assessment is interoperable. It's going to be able to link into medical records of primary care providers, and we're finally going to be able to address the needs holistically of a senior. I know my time is up. I just scratched the surface. I'd be happy to talk to any of you about this unique model and how we plan to scale it and the research that's wrapped around it.
Thank you. Well, we're all scratching the surface, but one thing I think that the panelists have in common is they've come across, developed, tested, worked out, maybe published about an innovative model that works where they are. And so my question to the group is about replication. What kinds of barriers do you find when you try to take what you've learned in one place to another place? Not only internationally, but even within states, healthcare systems, cities. Boz, you've been doing this.
Yeah, so we tried to replicate in 2 ways. The relatively easiest one was for Parkinson's going to another country. When we went to Kaiser is very different from the Netherlands. California is very different from the Netherlands because it's a well-organized chain of hospitals, whereas the emphasis in the Netherlands is on home care and community-based care. Kaiser has no home care. Kaiser has no community-based care. Yet our ingredients, our basic ingredients, we've mentioned Starbucks before, we've likened Parkinsonet to Starbucks. Our basic ingredients are like Starbucks. You've got your coffee beans, the milk, and the mugs. You want your double espresso. I like my triple grande latte. But the same basic ingredients are there. Our basic ingredients is, again, professional training, the patient as a partner, clever technology, and working in networks. And those ingredients could be implemented in a different healthcare system. And what struck us when we worked with Kaiser is that the wishes of patients were identical to Dutch patients. They're human beings. Copy-paste. The wishes of professionals were identical. You like to take pride in your job, to be able to add value to the lives of patients. The system was different, but the basic ingredients could be implemented. What we did learn, and that is also the reason why Parkinsonet hasn't been more widely copied in the Netherlands for other chronic disorders, is the reimbursement system. Because the reimbursement system in the Netherlands rewards institutions, and it's a fee-for-service system. We keep patients out of the hospital, so we deprive ourselves from our own incomes. Who wants to fund healthcare that transcends the traditional barriers? No one does, not even in the Netherlands. We're now speaking to the Minister of Health. We're close to solving the riddle. And that's why Kaiser was so interesting, because they are both the provider and the insurer in one go. So the person who invests is the one who harvests. And that's why Michigan is such a big struggle right now.
Mm-hmm. Have other people in the panels tried to work with other systems to show them what you're doing, or vice versa? And how does it work? Or does it work? Why aren't there senior centers like this one in San Diego everywhere?
Right. It's a great question, Paula. I think with respect to the dental center model and how we would like to scale and replicate that, we will go ahead and wrap research around our dental center. We're actually going to focus on the health outcomes and the expense that hopefully we're going to be saving the system by this new integrated approach in leveraging community assets and actually focusing on the root of problems, which are often dental problems. We're going to take that evidence, we're going to bring it to our Washington office with data in hand and sit down with policymakers to try to enlighten policymakers to create new payment mechanisms and models that will actually reward community-based organizations for addressing problems like this.
Yeah.
And Paul, if I may, I just want to, I think a big issue with integration of innovation, if you will, or sort of, disseminating and advancing better ways of doing things. In healthcare, there's a big leadership problem. I don't know, would anybody in the room, other than my team, whose daily job is to run a traditional health services organization, raise your hand. Everybody whose job is to run a traditional health services. So we've got a couple. Until the leaders of health services organizations view their number one job as figuring out how to make a better future, until the boards, the CEOs, the leadership teams prioritize with their time and effort that the most important thing is not doing what we did yesterday, but figuring out how to do what we're going to do tomorrow better, a better experience, better quality. And until we take on accountability that the future can be better, even with all the limitations. The limitations are there for everybody, but somehow some people have figured out how to do better. And within each of our organizations, we have to figure out how to move the ball ahead. I was lucky early in my career. I got to work with a pretty visionary CEO, Toby Cosgrove at Cleveland Clinic, who demonstrated day to day that the job of the CEO is not just to figure out how to keep doing what you used to do, but to figure out what's the next best way to do things. And so I think that we have a leadership issue in healthcare and aging services. And everyone that's in that space needs to look in the mirror. We need to have better plans. We need to resource leadership development. Because otherwise, if it's not embraced by the leaders, if the boards, the executives do not take it upon themselves to change things, all of these initiatives are just going to be one-offs. It's going to be like whack-a-mole, one-off, bolt-on stuff that was nice. It worked there for a few months. And there's a leadership issue.
I'll just add that to echo actually some of the concepts that came up this morning, the other area that we've been working a lot is actually trying to bridge the silos between most home health care agencies and the physicians who are involved in the care. So we have these people going out into the home, but there's actually very little communication back to that's meaningful, that's back to the physicians and the providers that are in general not going into the home. I think like Steve's experience, when patients are also getting house calls, that connection between home care and the physicians or practitioners doing house calls is really robust. But the big barrier that we've come across is that because there are so many different home healthcare agencies and they are often disenfranchised from the providers, it really gets down to the big issues of using different EHRs and the operability, like how do we actually communicate information across silos, and how do we make sure that the reimbursement and the regulation is really sort of incentivizing the sharing of that information. Because getting to see the home, the presentation just before ours, I mean, that those kinds of images, I mean, we're doing it for different reasons, but making sure that that information is getting back to the broader health system, we have to figure out how to break down that barrier.
Just maybe one more small addition is I think innovation and implementation is like a relay match. Many innovators like to innovate. So once they're done innovating, they want to do something new
Right.
rather than extend it. No, but that's a serious issue.
Yeah.
So our partnership with Kaiser forced us to write down our cookbook, which was in our heads, but we didn't write it down, so that other people who are less innovative but more solid and like to copy-paste could
Right.
take our cookbook and take it elsewhere. So it's a relay, and we need to hand on the stick from an innovator to an implementer.
Yeah.
And they're usually different characters and different personalities.
Boz, you are exactly right, and that is something that's very important to West, and we do the very same thing. We set up the blueprints for the community models that we have pioneered and piloted that are successful, and we are happy to give them to any community, any organization, any nonprofit. It's not proprietary. The most important thing is that our seniors benefit in this country, and we are happy to share all of our best practices.
Let me, before we open up to questions, ask about the sometimes forgotten part in the healthcare puzzle. Because most older adults who have chronic conditions, between them and their providers, them and their community, there is this family. And they're typically the ones who are reminding about prescriptions, making the appointments, keeping an eye on things, and they're not in the electronic health records, but they are crucial. And I'd like to hear how we can keep them involved as we move into new ways of providing health care, because it does not work without them, in my opinion.
Yeah, we're offering a new service now in our Radboud University Medical Center, which is a special consultation for the spouses. And the insurer said, we're not going to reimburse you because they're not sick. But we know that 40% of spouses of Parkinson patients are on the brink of collapse. If they collapse, they become dependent on much more expensive care, and they lose their independence in their homes. So we now offer, from our own pocket, a separate consultation for the spouses in the hope of keeping them fit. The ultimate solution is a value-based care solution where you reimburse the hospital for the health of your patient instead of for your services. And then your interest is to keep the family fit.
And do spouses respond? Do they come and use the service?
We had two wonderful observations. One is we were struck by the dramas that we heard from the spouses. They showed up massively. And then the patient said, but can we now also come without our spouse? Because we have our private... No, but that's interesting, isn't it? Yeah. Because we have our private issues too.
Right.
I want on the point of the caregiver, and the caregivers, in the health services, they're sort of the hidden patient who's suffering, goes unnoticed. And really, particularly in the home care setting, they're doing the lion's share of the hard work, and they're paying a pretty high price, personally in their family. So really, this is a crux of how do we improve care for elders with serious chronic illness, I believe. And I recommend I have no data or pilot to back it up, but I believe we should be looking very seriously at adding measurement on caregiver outcomes and caregiver experience. I've been impressed by the impact that Medicare's readmission reporting or Medicare's patient experience reporting, how that has brought people to the table, brought the issue of patient experience satisfaction to the table. We have healthcare systems across the country appointing chief patient experience officers. People are innovating on how to stop readmissions. I think measurement can be a great way to shine a light on things and motivate change, and we are not measuring caregivers. You can't look at a Medicare Advantage plan, a home health agency, a hospital, a physician practice, and see the outcomes of family caregivers. I think if we start measuring them, now I know scientifically and psychometrically measuring caregiver outcomes I'm sure is a challenging thing, but we ought to figure out how to measure caregiver outcomes. It will start motivating grassroots efforts at local levels to make the lives of caregivers better.
Cynthia?
I'll just add a couple of things. One is that, most older adults are actually accompanied to physician visits by a person, and yet there's data to suggest that we very rarely know really how to engage that person. What is it the patient would want them to be involved in doing, and how do we really sort of empower those roles? And so making sure that we try to figure out how to maximize the value of people who are accompanying older adults to visits, across the spectrum. So to be part of the sort of long-term planning and thinking, I think, is really important. And the second thing is just that I think that there's really been a shift in how we measure caregiving, the way caregivers were traditionally defined and what people are asked to do now. Many of the things that you've mentioned, being sort of the care coordinator of all the care coordinators and doing all those tasks. When we talk about measuring caregiving, sometimes we don't even measure those tasks. And I think that they have emerged over the last decades as we ask patients to do more and more things. There's sort of more healthcare management tasks, and making sure that we measure those and that we are counting those as part of the task, and that we're figuring out how to not make things unnecessarily complicated, that we're really focusing on reducing the complexity of everything that we have to do. Because again, when we just add up everything for each condition and each physician, it becomes untenable. Like you're living your life at the doctor, you're not living your life.
Right, exactly. The only thing that I'd like to add, I agree with everything on the panel. I see Lynn Richardson is here today from Mount Sinai, and Lynn is a terrific partner to West, and we're doing a really terrific research project on how we can empower informal and family caregivers in a really meaningful way, because the pressure upon them is, you almost can't describe it. In addition to that, there is a subset of seniors who don't have even informal caregivers. And that's a group that we're very interested in supporting in San Diego. And that's why it is so important to assure that you have got different opportunities to interact with a senior in a formal and informal way in a community to assure that all of those needs are being met.
Ross, you wanted to add something?
Yeah, just one little thing is, actually, and I totally agree about the vulnerable people without spouses or caregivers. That's a critical issue. So one thing we've just developed, and I'm really proud, is Parkinson TV. And Parkinson TV is, we've purchased a studio in my hospital. We have a panel of patients who decides about what topics we should discuss. And we broadcast once a month live television to patients and spouses and caregivers at home. And it's wonderful. The patients decide about the topics. And instead of transporting patients to the hospital, we transport knowledge from the hospital to the patients' homes. Now, what happens if the patient is now well informed and stays out of the hospital? We have a new solution where we have an experiment with the insurers to reimburse our hospital for every patient who no longer comes to the hospital. So I invest my money, not in doctors, I invest it in a studio. Isn't that exciting?
I love it.
But that's why,
Maybe it can.
But the way we've structured healthcare has happened upon us. Nobody designed it this way, consciously. And I think that's why we need this disruption, this little revolution, and turn our thinking around. Reimbursing for patients who are no longer coming to the hospital is a game changer.
Yeah. I think we have the first questioner. Yes, please.
Hi, I'm Jane Rhodes from Biogen, and we're very interested in measuring outcomes, applying digital technology to better measure patient outcomes, particularly in multiple sclerosis. And the question I had was on this notion of measurement, because we all throw around the terms outcomes and value and measurement very liberally, but it's incredibly difficult to align around evidence, outcomes that will lead to evidence generation that will result in reimbursement by payers and acceptance by providers. So I wondered what your thoughts are on how do we do that? How do we really leverage the power of technology to apply it to measuring outcomes in a way that lots of fields, neurology and other fields and care for the aging are really going to be able to take advantage of it. I think, right. Steve, you mentioned this as being a challenge. It is a challenge. How do we solve it? Yeah.
Who can talk about measurement?
Sure. I work in an environment where we're an elder services provider, okay, and most of what we do is within the construct of the Medicare program. And so we cross all different diseases, patient scenarios. And what I can say, I'll say it, I believe that the framework that Medicare has built around measuring the performance of providers, while imperfect, it's touching on really important things. What's their care experience? Would they recommend the care that they received to somebody else? How much did it cost? Is it about average cost, below average cost, above average cost? What are some basic high-level public health outcomes of that care? Did they get their immunizations appropriately? Did they get medication reconciliation after an event? So I do think that where we do have some high levels of programmatic measurement that we're heading in the right direction, I think that we should be thinking about how do we add to that pool of measurement to address caregiving issues and maybe some more of the social determinant issues to sort of bring to light things like housing, oral health, and other things that might be playing a role. But in terms of disease-specific measurement, functional measurement, I'm not an expert and I really can't comment. But I do think that measurement can be a great policy tool to shine a light on things to then create the competitive spirit. Nobody wants to be the worst at something. I remember when the readmission rates came out for Medicare, 2009. There was no payment change. Hospitals didn't have payment penalties because they had higher heart failure readmission rates. But the leaders recognized, wow, we don't want to not be good at something. We have to figure out how to make sure we get better. I think measurement, we should be thinking of it in terms of aging services. How to use measurement to motivate people to try and find new ways to be excellent.
But it's
I'm sorry.
The point I was trying to get at is that it's stifling innovation in that to bring an innovative device to the clinical setting now, it's almost impossible to get a fast track to reimbursement. To get a CPT code for a device that's going to have an impact takes years. And so I think it was mentioned this morning about how we innovate around these things. How can we, as a community, kind of make that happen faster?
I will make two comments. One is finding a reimbursement for single solutions is a dead end. And don't even try it. That's why I think an integrated value-based care reimbursement is the way to go. And then you decide whether you invest your money in nurses, in a golden toilet for your patients, or in Parkinson TV. And I own the budget and I decide now. I don't think I will ever get a reimbursement for Parkinson TV, but I pay for it from my budget. That's one. The second thing is we have strong opinions about how to measure quality of care. And I totally agree with Stephen. Transparency is the way to go. The way we do it in the Netherlands, I think, is exciting in three ways. We've got Parkinson Insight, which is the first national quality registry that measures care in networks and multidisciplinary care. And it's exciting in three ways. First, doctors only complete information that is needed for case control mix. So they don't complete outcome measures. The outcome measures come from patients, patient-related outcome measures, and we use a CQ index, quality of care as perceived by the patients. So that's a factual experience of how you've experienced your care. Did I get information? Did I always see the same physician? Was it an integrated team approach? And the third thing is, we feed back that information in a transparent way. It's on the web, but not at the level of individual physicians or doctors. That's a name and shame culture, but at the level of regions. And thereby we promote multidisciplinary care. And what is happening now, we've got 66 regions in the Netherlands. We've got good ones and we've got bad ones. The good ones come together and they say, look, we're number one. How can we improve ourselves even further to maintain our lead position? The bad guys say, we look like shit. What can we do to improve our business? And they should hop on the bus and learn from differences. And I think if you need transparency for one thing, it's about learning from differences. It's not a stick to hit the bad suppliers. It's learning from differences.
Gentleman over here.
Thank you. Name is Howard Reese with the Castleton Group. We focus on promoting very unique telemedicine solutions, but I want to go back to the area of caregiver outcomes. And just a quick thought, I mean, you mentioned patient-reported outcomes, thinking of the organization, PCORI, Patient Center Outcome Research Institute, and maybe there's an opportunity to work with them in the area of caregiver outcomes, and maybe they've created a model that would work in what sounds like an area for a great research project.
Yeah, that's a very good addition. There are validated outcomes like the Carer Strain Index, which is part of our National Quality Registry. I haven't seen the results yet. End of the day, I think your primary outcome is probably an independent senior living at home. And that requires a fit spouse. So you sort of incorporate that into your gross overall outcome measure.
Yes.
This wonderful presentation. My name is Rajiv Ramchandran. I'm an ophthalmologist at the University of Rochester and lead a population health and telemedicine initiative for promoting eye care in the region. You brought up great points about working with vertically integrated organizations, but the bottom line is money, is sort of who funds all these things. We're still relying on Medicare and insurance-based payments here in the United States, and for vision care, just like dental care, a lot of things aren't covered. Even glasses, simple glasses aren't even covered for folks over 65, and if we're starting after 65 too to have insurance. What about before 65? What about before they get to the point of being aged? What can we do to have innovative solutions for the financial backing of healthcare? Do we have to rely on a fee-for-service model, insurance model, or are there things that we can do to really be innovative in terms of how we're paying for things, going direct to consumers? What are your thoughts on that?
Shelley?
Yeah, so the model that I outlined actually uses philanthropy to kickstart a new model. So again, it was about $1 million that the foundation decided that we were going to deploy to kickstart a new model of care to leverage these community organizations in a meaningful way. At the same time, we know we're not going to kickstart something, that's going to kind of be dead on arrival, that without our philanthropic support is going to go away. We are able to harness a Dent-a-Cal reimbursement in the state of California. We do have a public-private partnership with our AAA, our local HHS. In addition to that, we are going to demonstrate better health outcomes. We're bound and determined to do it. And with that data, we're going to the agencies in Washington, D.C., and we hope to influence new payment mechanisms and reform. So we see this as a journey, and we know it's not going to take a year or 2 years. It's a multi-year journey. But the importance of philanthropy kickstarting new innovations is really important.
Anyone else want to chime in?
No, other than the fact that your system is sick, and the fee-for-service system is really harming many innovations in the United States. I think it's the same in the Netherlands, but and I strongly believe that a fee for outcome for integrated care is the way to go, because then you're rid of the discussions about isolated interventions, whether or not to reimburse these. That's a complex process, but you can start with beautiful innovations like what's happening in California, and start with a fee for outcome system there. It's all about trust. This whole transparency issue, that's why I said it's not a stick to hit the bad supply. It's about trust and confidence. And I think there's a lot of distrust now in the healthcare system. If we play the confidence back into the hands of the suppliers, like the nurses who are working their butts off now to do the right thing, and then just create transparency to show outcomes and to learn from the differences, that's the way to move forward.
Right. And boss, to make sure that we have the toolbox and the blueprint that we're going to share all of our best practices.
Yeah. And I think it's hard to argue, that we need more money. When you look, we spent $500 billion on Medicare alone last year. It didn't include Medicaid, private insurance, Medigap, out-of-pocket expenses, already 3% of gross domestic product, on its way to 5% with the aging of the boomers. We're already spending enough money, so the idea that we need another billing code for another thing, in some ways, I think when you look at the big picture, seems, might be a bit absurd. That said, there's a lot of gaps, and so there's this paradox where there's a lot of spending, but there's still a lot of suffering. I think that it's in these holistic models, these community-based, multidisciplinary approaches where maybe we can get at global funding or at least, retrospective reconciliation of funding and start to think about how do we resource different things, within that package better to, get better value in the end. It's not an easy thing, especially when you have a specific issue like incredibly important like eye care that you're trying to advance. I do think that the winners, the winning communities or the winning entrepreneurs are going to figure out how to be in that. I think that the grab sort of that high tech, high innovation, low cost space. It's not going to be about finding things that are very high cost. We've got to figure out how to address the costs somehow.
I think that's our time. I'd like to thank the panel for their insights and thank all of you for your attention.
Yeah, on behalf of everyone, I would like to thank Paula for running a thought-provoking panel, for Beth, Cynthia, Steve, and Shelley for all your comments. It's been very useful, and thank you very much. After lunch, we are spending 1 hour of a networking lunch. It's ready for you here in this beautiful scenery. We have some amazing technology presentation coming our way, and we'll end the day with a jazz reception. So we have a chance to enjoy sunset view with great jazz band, live music coming up to enjoy the end of the day. So I would like to thank Verizon for sponsoring the lunch break, and please join us for lunch.